Hello, everyone, and thanks for joining us today. My name is Paul Adepoju, and I'm the community manager for the International Center for Journalists. The goal through the ICFJ Pamela Howard Forum on Global Crisis Reporting, we are helping journalists across the world to first of all make sense of different crises and to also empower them with more than enough information to improve their ability to report on the various crises that we are dealing with across the world. When we talk about crises, in recent years, the COVID-19 pandemic has been front line and center of global media coverage. We have seen journalists across the world trying to readjust to reporting this COVID pandemic. But since then, several other crises have emerged outside of the health sector and within the health sector itself. And more recently, monkeypox also gained global attention. And even though this is a disease that countries like Nigeria has been dealing with since the 1970s, the rest of the world, many people in the other parts of the world got to know monkeypox this year. And in addition to this, the AIDS epidemic continues to rage on, even though there are indications that the world is accelerating its fight against is accelerating its fight against HIV/AIDS. There are still some topical issues that still needs to be addressed in this response. So, which is why today we are having no presentation, just a vast discussion on topical issues that we believe are of interest to journalists across the world. So let me start by introducing a veteran professor who is vast in the area of global health and is quite aware of all of these issues. I'm talking about Professor Oyewale Tomori. Professor Oyewale Tomori is a Nigerian, but he's a citizen of the global health ecosystem. Thank you once again for joining us, Prof, and we're happy that you can join us today. How are you doing today?
I'm fine. Thank you very much for inviting me to this meeting. I'm pleased to be here.
And we're also glad to be joined by Dr. Abiola Adepoju, who is actively involved in the HIV response in Nigeria. How are you doing, Dr. Abiola? Are you there?
Yes, thank you, Paul. I'm happy to be here. Thank you.
Yes, so thank you very much for being with us today. And to all the participants that are joining us in different parts of the world, as usual, we are always interested in knowing where you are joining us from. At least that will give us an idea of how you are peculiarly affected by the issues that we are discussing. So if you can use the chat box below the Zoom live stream video that you are watching, that will be appreciated to tell us where you are joining us from. And if you are watching us, yes, we are live on Facebook. If you are watching this live stream on Facebook, also use the chat box below the Facebook video that you are watching. To also tell us where you are joining us from. And I think a way that I would like to start with was something that became quite obvious with the the recently held AIDS 2022 conference in Montreal in Canada. And that is the fact that Canada is one of the countries that continues to advocate for global health. But we see something that happened, which actually largely mad that conference itself. So I'm sharing a picture now. So this picture. If you look at what the message on the side of the street was, it was meant to be the final session of the day. The goal of the discussion of this session at the World AIDS Conference, AIDS 2020 conference, was to discuss stigma related to HIV in clinical settings. But unfortunately, every panelist on that was supposed to be there could not attend the conference because they were all denied entry into the country. So because we are now seeing, and this is not just the first time, if you follow the discussions on Twitter and of course the publications, there are increasing calls for these conferences not to be held in countries that are really, really difficult for foreigners, especially those that are directly affected by these diseases, to be able for them to attend. And in addition to this, I'm going to join everything together. I'm going somewhere. In addition to this, if you also look at the monkeypox outbreak, and which is currently ongoing, about 2 weeks ago, the World Health Organization declared monkeypox to be a public health emergency of international concern. And the goal of it was to ensure that rapid actions are quickly taken to stem the spread of this particular disease. And while vaccination exercises are already underway in the US, in European countries, the last information I still had was that African countries still do not have a single dose of the vaccine that has been found to be effective and confers protection against monkeypox. So we have a scenario where, as diseases happen, the global community pledges support to ensure global actions are aggressively taken to address them. But when some actions are required, as simple as granting people visa to attend global health conferences, or to actually share available vaccines to protect the rest of the world, we still see the world dragging behind, and some of these countries reluctant to actually take actions that are supposed to be taken, which reminds us of the early days of the COVID-19 pandemic, when we saw nationalism to be front line and center of the response. So that is what we are trying to discuss today. And I will start with Professor Tomori to react to what I just said. And is there a connection? Is it intentional? And does it mean that we've not learned anything by mainstreaming nationalism in global health response, as we saw in the COVID-19 pandemic? What do you think, Professor Tomori?
I've been asked this question before. Am I surprised at what is going on? And my answer to the person was that, are you surprised that the sun rises from the east every morning and sets in the west every day? Nothing has changed. And I think unless those of us in the African region realize that the solution is not dependent on the globe, it is for us to do our thing ourselves. Until we begin to appreciate that, the situation will continue to be what it is. So you describe what happened with Canada. You remember what happened with COVID. You remember, we see what is happening with and monkeypox now. Things are not going to change. And I think we're pretending about equity. Equity is not something you get on a platter of gold. Equity is not something you get by begging. Equity itself, by its own foundation, is self-interest. The Bible says, love your neighbor as yourself. It didn't say love him more than yourself. So you love yourself first before you love your neighbor. And I think we begin to appreciate that in the African region. We're going to continue to be begging and whining for equity. You fight for equity. You go after equity. You put something on the table. You contribute to equity, not consume equity. See the difference between India and India of 1947 and India of today. We're talking different things. They went outside and put themselves in a position where you can talk about equity. 1947, they were begging everybody in Canada for whatever it is they needed. Today, they are producing virtually all the vaccine that the world is using. And one good example, when Britain put all of us under the red, amber, green, whatever it is they call it, which is the rag, there's something, and put Africa, and say, if you didn't use my whatever it is, you can't come into Britain. What did he do? Ramaphosa went and everybody started begging Britain, oh no, this is equity, inequity, this is racism or whatever. What did India do? India called the foreign affairs of UK and said, no problem. I have COVID, you have COVID, whatever it is your own is. If you don't get my own, I don't get your own. Britain capitulated that same day. That is equity for you. And until we in Africa begin to realize and appreciate that we need to put our money where our mouth is, we'll continue to suffer inequity. And remember, when there's turbulence in the plane and the mask is coming down, what did they advise you? They said, take care of yourself before you do that of your child. That is equity. Africa has to begin to appreciate that before we get to, otherwise we continue to beg and nothing good will happen.
Yeah, thank you very much. I'd like to bring in Dr. Abiola at this point. That's a stubborn train.
Okay, thank you. I think, can you hear me?
Yes, we can hear you.
Okay, so thanks. I think I agree with Prof's perspective that we see the whole issue around inequity playing out here in the context of, we saw it in the context of COVID, and now we are seeing it in the context of monkeypox. So that tells us it's not a mistake, it's not by accident, it is deliberate. And I believe that we live in a space, a global space, that a harm to somebody is a harm to everybody. Diseases don't respect border. We travel through the same airport, through the same borderline and all that, and this problem can be easily transmitted and all that. So I think there is a need for us to see ourselves, the global south and the north, or call it low and middle income country and the west. We should see ourselves as partners rather than as impostors. Whatever disease, whatever benefit should come with a disease outbreak or pandemic response, Africa should also be prioritized. I know we're talking about monkeypox now, even a lot of things in HIV coming up now. And what people are advocating for is that these things should also, Africa should be prioritized. For instance, we have a new drug for PrEP, pre-exposure prophylaxis now, an injectable that you can take every 2 months, about 6 times in a year, which is going to be remove a lot of headache in terms of coming. So, but again, the question is that with all these things come to Africa, will Africa be part of this agenda? So I think 2 things will need to happen. There's a new movement now called Decolonizing Global Health, trying to talk about this inequity issue and all that. But I think we need to, number one, the West and the North need to see themselves as partners in terms of these innovations coming up, not just to the West, not just to the, but also to African countries. And the second thing is more or less similar to what Prof said. African countries need to now begin to see themselves, put themselves in the driving seat, not just as a recipient. We need to start doing some things that are crazy, things that are, that are disruptive, trying to, things like locally manufacturing our own drugs and local manufacturing of our own vaccines, which is also going to come at a cheaper price for our people. So these are some of the things so that we'll be able to have a voice in this whole global health discussion and be able to say, no, this is what we want. Not just doing, we must buy our own, we are also doing our own manufacturing, support our local manufacturing and all that. These are some of the things I think we need to take more on the driver's seat rather than just awaiting somebody from somewhere to receive from them. Thank you.
Yeah, thank you. I'll also stay with you, Dr. Abiola, because the visa issue really prevented many people from even having an idea of what really happened. It actually was the main coverage from the conference. But you were able to attend in person in Montreal, Canada. So for you, what do you think are the major outcomes from that conference that did not get the headline that could suggest where the world is moving towards HIV eradication?
Okay, so thank you very much. First and foremost, I sympathize with those who were not able to come because of visa denial issue and all that. And I think sometimes too, what happened in Canada was also not just about Africa alone. I also come across a lot of people in the Western world who actually denied visa, and that's been condemned throughout the conference, from the opening ceremony to different sections to the closing ceremony. People actually condemned this. But I've been denied visa before to go to Netherlands, Schengen, and I know how I felt then. That was a big stage for me to talk about some things, but I never had that opportunity to go. So I know how it feels, when you have something to show, when you have something and information to pass, and then you are denied just because of inequity that we're all talking about. So in terms of the key highlight I see from AIDS 2022 conference, I work in the HIV space, and one of the challenges of HIV globally now is testing, getting people to test. And there are key population, there are some particular population that even though we have made progress in HIV response, what we call the UNAIDS 95, which is getting 95% of people to know their status, 95% of those who know their status to be on a sustained antiretroviral, and 95% of those on antiretroviral to be virally suppressed. And the U equal to U message, which means that once you are, when you are when you are suppressed, you are untransmittable. Undetectable is equal to untransmittable, which is a very key message, scientific message that people need to spread. And that came very bold in that discussion of some data from countries showing that really when you are undetectable, you are untransmissible. But there are also a lot of data on the poor awareness around U is equal to U message. So you see that the people are taking ART drug, but they never heard about U is equal to U. They don't know that if they are adhere to their drugs, their medication, and they are virally suppressed, and they won't be able to transmit HIV virus to their partner, to their children, whether you are a pregnant woman or you have a partner. If you are committed to your drug, you are adherent to your drug, and you are virally suppressed, you are not like, and you are undetectable, which means that your virus is almost like less than 0, less than 20, depending on the machine. You are not likely going to transmit that virus. So that gives that's optics, the need for us to really promote that message among people living with HIV, among those that are on treatment, to be able to promote that message, and that message to travel wider and wider. So low awareness around U equals to U came out very strongly in this 2022 conference. The other thing is that the target, if you look at the SDG target, last year, the target was to have new infection of 500,000, but unfortunately, globally last year, about 1.5% new infection were recorded for HIV, which is very, very lamentable, very pathetic situation. Despite all the fight, despite all the progress we have made in HIV domain, new infection is still increasing. 1.5 million last year is nothing good. And one of the tools, we have all the tools available, and one of those tools is HIV self-testing. Being able to have, and specifically for some population, for instance, men, we all know that if you go to hospital, even in sub-Saharan Africa, they are likely populated by women, whether for ANC or for one thing or the other. Men rarely go to conventional hospital. And one of the strategies, one of the tools that is available for men to get them tested is actually this HIV self-test, which is a screening tool. But we still find out that several countries have still not adopted a policy. This policy on HIV self-test is not still embedded in most national program response, Ministry of Health response, and it's very critical that we adopt this technology. We have all the tools, the community-led initiative, HIV self-testing. We need to use all these tools to be able to increase our first notified agenda. So that also came very strongly in its 2022 conference. And the government of Canada actually announced also during that conference that they are committing $18 million to HIV self-test over the next few years. And this is also very welcome development from Canadian government. Also, there's a new partnership between what they call them, Medscape and PHEIC on this $1 announcement for HIV self-test. So one of the challenges in countries who have adopted HIV self-test, for instance, Nigeria has adopted HIV self-test since 2018. We have a national guideline that integrated HIV self-test into national ETS guideline that was launched last year. And we have distributed as a project, for instance, up to 200,000 HIV self-test kits in the country right now. We have also advocated, so we have new product, new manufacturer, new product in the country, as opposed to one product that we have before. We're not sure, we now have about 6 products. Some of them also are even blood-based products. So, but one of the challenges is that the cost, the price of HIV self-test is quite high, and it's not affordable by many people, about $3. You know that the exchange rate is also not helping the matter. Our exchange rate, Naira to dollar ratio, is also, going up and up every day. Similar situation with some other sub-Saharan African countries. So there's a need for us to beat down the price. And I'm happy with that announcement from PHEIC and Medscape partnership that this product will come out at $1. But one thing that we also want to appeal for is that even though they have agreed that this product will come back at $1, it has to come at $1 to the end user. Because we know that one of the challenges is that when this product comes to the country, it comes with additional cost of transportation, supply chain, storage, warehousing, and all these things. But $1 is around 600 Nigerian naira now, which we think relatively most people might be able to afford it. But if it has to increase beyond that, after you have added all these other expenses, I think we'll just want this $1 to come at the end user price. I think that also comes very clearly in this 21. The other thing that's very important is the introduction of cabotegravir, what we call CABLA for short, which is a 2-month injectable for pre-exposure prophylaxis, especially for key population, high-risk individuals. That was also announced by UNAIDS and WHO during that conference. It's also another welcoming development. And also came out very strongly. But however, like I said, there must be equitable distribution of CABLA. It shouldn't just be for the high-income countries. We should also make sure that African countries, low and middle-income countries, also prioritize in the distribution and manufacturing of this new product, which is going to help to change the narrative, decrease hospital visit. Compliance is likely going to be better because an injectable, you don't have to swallow the pills every day any longer. So that also came out very strongly. And also the role of community. Anywhere you go to, emphasis on community in achieving epidemic control for HIV self-test. And I'm also very happy with the section with Dr. Tony Fauci, giving us a historical perspective from 1981 to date, telling us about how PEPFAR has responded and all that, about 84 million cases since 81 to date, and from 1981, from the last conference from Canada to date, about 70 million new cases. A lot of progress has been made and all that, but the role of the community is very critical to achieve epidemic control, and key population also need to be prioritized. But however, I keep hearing key population across all the conferences. The global data do not necessarily reflect African data or Nigerian data. So each context is different. Key population is not really the major driver in most African countries. So we need to really emphasize data. Even this is the global data saying that 70% of new infection in 2021 came from the key population. Every country knows their epidemic, and the support that the West is giving to African countries must also be based on the evidence, their epidemic, their population, their own data, rather than using global data to support countries in Africa. Thank you.
Wow, that's a lot of updates, and I think unfortunately those they were not many journalists did not pick those ones up because of the attention that the visa issue got. Prof, quick thoughts regarding what are your thoughts regarding the current state of the global response to HIV, and what it seems to be. Do you think it has been effective? And do you think there are some aspects of this AIDS response that we don't seem to be introducing or maximizing in the current responses to the different outbreaks that the world is responding to at the moment?
Yeah, I think my colleague has covered quite a lot of ground about some of the issues they're talking about. If you can even cover half of that, there'll be a greater solution to the HIV problem. The very, very important things he has raised, and how do we get that domesticated, I think will be the most important thing. The conference outcome, but then with all the next conference, what progress I will have made. I mean, that would be the way we push, not just at the conference center, but back at home at our different locations, what is going to happen. And I think this type of discussion, we journalists are getting involved, will be one way to domesticate that, get it down to our different countries. Some of the important things he said, the new things he's talking about, how do we get that one being practiced in our different countries? That to me would be the success of that conference.
Yeah, so we are talking about monkeypox now. Everybody is talking about it. Everybody's aggressive, is main front and center. Probably now more popular than COVID in the news cycle. But monkeypox is not new. It's not new at all, especially in countries like the Democratic Republic of Congo, Nigeria, and a few other places. But one of the things that struck me, and I think it was obvious in the early days, while the WHO was reluctant to actually declare this a public emergency of international concern, which I think is the fact that until now, nobody was talking about rolling out vaccines to respond to monkeypox. But when it started happening in developed countries, in the UK, in the US, and elsewhere, over the night, these actions began to be taken. So what does this fundamentally say about monkeypox? And why do you think the did not take such an aggressive action as we are taking now? And do you think we still have the chance to actually end monkeypox within a short period of time? Prof?
Thank you very much. Funny enough, I'm actually on the opposite side of what is happening. For me, I thought that the declaration of it as a fake is fake in itself. Fake, but F-A-K-E, because Europe had already started acting before it was declared. People are already taking action, even before it's there. Even after it was declared, America declared this its own national emergency. And I think I keep saying that we in Africa have a lot of things to learn from that. I can't quarrel with British or the British people or the European people for taking care of their people and taking the action they take without waiting for WHO. I mean, first of all, it was a national emergency before it becomes an international emergency. So why are we waiting for WHO to declare it for us? In any case, it was almost like a terrorist veto over the commission, the group. I mean, they didn't agree that it should be declared a visa, and they had their reasons. Both sides had their reasons. One, I mean, the declaration came 50 years too late for Africa, and it came 2 months too late for Europe because they already taking the action they needed to take. And so the fake it's going to end up, nothing is going to, sorry to say, and not much is going to happen because those who are taking action are already taking their action. And the rest of us who will never take action will continue never to take action because we're going to keep depending on vaccine, which will come from outside. First, the vaccines are not enough. And I think the approach to use vaccine to stop the thing, I would think what has happened in Africa over the last 40 or 50 years, I think there are more cost-effective or more productive result that we can get than rolling out vaccine at this time. First, we don't have enough vaccine. Secondly, this was a disease which over the period, how many cases did we have in Nigeria in the last, from 2017, take from 1970 to now? We're talking of less than 1,000 cases reported over the period because this is a self-limiting disease. If you take the proper action, good surveillance, good laboratory support, isolation of cases, prevention of direct contact, you can actually nip this problem in its bud because it's a self-limiting disease. Therefore, we in Africa should use what we have rather than hoping for vaccine, which will never come. All these years that the thing has been with us, who knows what is the real reservoir of the diseases? We don't know. And I don't think it's a major cost to get some research on One Health group, veterinarians, everybody coming together to look at this kind of study. Over these last 50 years, we should have been able to contribute something on our own side to say, look, these are the hosts, these are with this. And because when you know the host, then you can begin to plan your prevention and other kind of. Now, everybody says, is it a monkey disease? Is it a rodent disease? Is it a squirrel disease? Nobody knows. And therefore, so when we come out in Africa and say we ban bushmeat, I think that's one of the most stupid things that can come out of anything because we're talking out of ignorance. I mean, when you say ban bushmeat, the man who is eating the bushmeat is eating the one that is cooked and already well done. So there's no virus in that one. I would be worried about the man who is trapping the bushmeat. But that message we're giving out is not the correct message. So we need to do better than we are doing. Take advantage of the information that we have and use it properly. Again, I keep saying the declaration by WHO is not going to make any difference to what is happening. People are talking, oh, the inequity that came with COVID. Is it not going to happen with the monkeypox? I said, it's already happened. So what are you talking about? And it's not I mean, sorry to be this thing. I don't think much is going to change over this issue. Europe will take care of itself. America will take care of itself. And nobody will think of Africa. Africa itself is not even taking care of itself. And that's where the problem is.
Few weeks ago, I wrote this article in Scientific American, and I spoke to some African scientists regarding their perception of the global response to monkeypox. And it seems to be a widespread condemnation of the WHO, how the Global Health Authority has handled this response. And every time I look at the current landscape, everybody knows the textbook solution to disease outbreaks, but it seems as if it is increasingly difficult to get the entire world to act together. So which is why I'm particular about the future of global health, especially the continual relevance of institutions like the WHO. So what do you think, considering it seems to be that everybody's taking care of itself now, and the best way that everybody seems to be advocating is individual countries taking up their own responsibilities. But do you still think there's still going to be the WHO is still going to be frontline and center of global health response in the future? So I want Prof to start, and I would like Dr. Abiola's thoughts too on this.
We will still need the WHO, especially those of us who will not take care of ourselves. I'm talking about us Africans. Let's be frank with each other. The world will first take the issue of the COVID when it started. The thing is, oh no, these European people are hoarding this, they are doing that. And I ask my colleagues a few questions. I mean, let's be realistic. Supposing the COVID was happening in Africa, killing all of us in Africa, and Africa had the vaccine, and there was no case or few cases in Europe, will you give vaccine to Europe? The answer is no. So let's be frank and look at what is happening. We talk about global equity, and it's not going to happen. The only way equity is going to come is when, I mean, you remember the time of nuclear weapons. It's called a balance of terror. You have, I have, then we all behave. We must continue not to beg in Africa. We must continue to also contribute. I get the example of India. India could walk up to Britain and tell them, I'm not using your COVID if you.
I think Prof is frozen. Dr. Abiola, can you come in?
Yeah, so thank you. I think, but I think I agree with a lot of things that Prof has said, what I know is that, but for the sake of equity, equity is also about people, vulnerable people. So one thing I believe is that I'm not one of those people that believe that, so I believe that people should pay for their health care when they fall sick, whether it's pandemic, whatever. But I also believe that somebody has to pay. Is it that they do not pay? And if the donor is not ready to pay, the government should be able to pay. But we should not allow anybody to die just because they don't have money, to get some. So if you look at it from that perspective, I feel like African government also need to wake up. So yes, it's good to rely on people bringing things for all. Maybe we don't have all the wealth and all the income like the West will have. But also, we should also be, I was impressed, I think during COVID period, there was a particular African country that sent maybe something to China. I can't remember exactly that very African country, but there's a very particular African country that sent, I think, vaccine or something to China just to solidarize and support. Those kind of things need to happen in Africa. We must be able to look inward. So if donor is supposed to give us some things and they are not giving us, the government should be able to rise up to the occasion and be able to. So I had the opportunity to attend a session from a Nigerian that reviewed the epidemiology of monkeypox from 1917 or so to date. And also Meg also came from the WHO. Meg is the head of the emergency unit or so in the WHO. And if you look at the epidemiology so far, as at a week ago, just about 292 cases in West and Central Africa, out of about 21,000 plus that we had. But one interesting thing is also that we have mortality in West and Central African country, about 3 cases from Nigeria, and I think one from, so we also have cases from Brazil, death from Brazil, and some other, African countries, as I one week ago, about 21,256 lab confirmed cases, and majorly in the United States. 5 deaths, 3 of them were in Nigeria, Democratic Republic of Congo, about 2 of them, 1 from Brazil, 2 from Spain, 1 from Ghana, 1 from India. So one thing that caught my attention is that we also have, even though the death rate are few, we have 2% of the global monkeypox infection in West and Central Africa, but mortality also is coming up. So that also tells us that African countries need to start thinking about something, maybe in terms of vaccination, promotion. Like Prof said, we also need a lot of research. It's not every time that it's from the West, evidence will be generated on some things. these things affect us. We must also be able to bring teams together to research some of these things. Like Prof said, we don't know the exact reservoir of some of the monkeypox. There's nothing bad from African country, collaborating, forming a research or coming together to look at these things and be able to bring out evidence that the West can also adopt and all that. So I think these are some of the things. Even if we don't have money to generate vaccine, to manufacture vaccine, research, is something we can look at and be able to bring out this evidence. We have intelligent people like Prof and some other people that are very versatile in these things. We should be able to come together as African leaders, be able to put resources together, generate evidence, research gaps in some of these diseases, and be able to bring this to the fore for the other people to learn from us that will inform further policy and some other research in the future. So I think these are some of the things that we can do. But I think that mortality kind of thing actually drew my attention that we now have 3 deaths from monkeypox in Nigeria, Brazil, Spain, Democratic Republic of Congo. So we need to begin to look at it. And also, one of the things that also came out in that section is that atypical symptoms are also being, we are now seeing more of atypical symptoms in monkeypox. And also, the fact that we are also having a few cases in West and Central Africa will also be because of our surveillance system that is not strong enough. So all these things, bringing them together, we really need to do better as African country. But really, the people that are affected should not suffer just because somebody is not supporting us, whether it's donor. We don't have excuse. If the donor is not supporting us, African leaders must also wake up and to the occasion and be able to fill this gap so that people that are really at risk or vulnerable can benefit from some of these therapeutic vaccine and also demand creation in terms of promotional messages around monkeypox. Thank you.
Prof,
sorry, I got.
Yes.
Yeah, I'm back. Somebody doesn't like what I was saying, so he cut me off.
Okay, I want you to complete your thoughts then before we go into something that I think is important. Looking at the coverage of monkeypox now, what guidance and what do you think journalists ought to be focusing on, and so that their reporting can be more effective?
I think one of the, initially when this thing started and was popping up in different parts of the world, I mean, especially the European, so-called non-endemic, everybody was stunned and we didn't know what it was. But then as we got more information about the source, there was a common source, and then it became clearer what was happening. You can't do better than having good information. I think Biola said something about that one. Research to provide you the proper data so that you can use that to plan. And then getting the right information. I mean, you remember when this whole thing started, there was a time I had some discussion with some of the journalists. The cases were happening in Europe and they were using my face as the one that had the case. And I said, look, these are part of the fraud that is being completed. You cannot have the European pox and then you put the face of an African there. These are areas where I think journalists should come together and talk with strength and say, look, this is the reality of what is happening. One other point that is happening right now in Europe, how is this spreading? Why is it spreading so fast? Because there was some change in human behavior which escalated or amplified the spread of the disease. That kind of information, without stigmatizing, as you said, need to be told so that people can be properly advised. Again, not to give the impression, because you can get this infection, not just through sexual transmission, direct contact and all those things. Provide all the information to the people so that we can limit the spread of the disease. And if we have been able to limit the spread up till now, from the time we started in 2017 Nigeria to now, DR Congo seems to have a more severe kind of situation. One other point about DR Congo will report 20-something thousand suspected cases and only be able to confirm maybe 10% of that. That's an area we need to take to our government. Why can't DR Congo have the necessary laboratory facilities to confirm all the thousands of cases they are getting? Is it something else? Is it the same thing? Where is the problem? I think journalists should be able to probe with us, with their scientists, to get the right information, to get back to our government so that they know that these are the areas that need intervention. back to my country. I mean, when we keep talking about the fact that we don't have resources, we don't have money. I think our problem is not resources or something. It is misuse of resources. That message must go out clearly. In a country where a person can pick up 100 million to buy an election form, don't tell me you don't have money. In a situation where majority of your people take this money out of the country, and then you tell me we don't have money. It's just that we're not using our money properly. How much is it going to cost a One Health project to look at reservoirs in Africa or in any country in the region? How much is it going to cost compared to getting 100 million for a form? These are issues that we need to be discussing, and journalists should be going out, pointing this out to our people, to our leaders. We can't continue to be dependent on everybody when we actually have the resources. Over.
Yeah, thank you very much, Prof. And so if I will come in and raise this discussion around the current outbreaks in Nigeria and especially in some African countries and the rest of the world. What is really driving it? When and how do you think are there any concerns about how these outbreaks ought to be reported? When last week at two different press briefings, the WHO, the World Health Organization, and the African Center for Disease Control suggested that what is driving person-to-person sexual transmission, that is largely driving the outbreaks elsewhere, is entirely different from what is happening in Africa. But when you look at the data in Africa, we see that, especially in some countries where this disease has been reported for years, that there has actually been the rate of the number of cases this year actually increased more than before. So how do we explain this? And Africa CDC and I think WHO also affirmed that they are not actually tracking the sexual orientation of people yet in the epidemiological surveys. Do you think there is enough justification to start tracking that also, so that we can actually be able to establish this? So the question is this: what do you think is driving the epidemic in Africa? Is it different from the rest of the world? And do you think Africa's surveillance details are expansive enough for us to confidently say that what is happening elsewhere is actually not what is driving the outbreak in Africa? Prof.
Yeah, thank you very much. Truly, what is driving the epidemic in Europe is not the same thing that is driving it here. And you remember I made the point that this has been on like 2017 for almost 5-6 years. We only reported 1,000 cases. I mean, given the fact that yes, our surveillance is not that good and all that, but still, if it was there, you can't mix pox lesions, you know, on somebody's surface. But there are two different things that are driving this epidemic, and we know what is driving it in Europe. I mean, again, first of all, direct contact is one of the what we know, but that sexual activity also amplifies it. I mean, let's face it. In our own region, the fact is that again, let me go back to DR Congo. In DR Congo, they are reporting these cases more in areas where they have not reported before. Again, I think it is part of improvement in surveillance, awareness, and that is so more people are seeing it in the far removed from the urban centers, in some of the remote areas. And that's expected. And these are some of the questions we are raising. If we don't know the reservoir, we don't know where we're getting it. So these are pointing to some of the things that we need to track those issues. Bear in mind, when you talk about rash, there are all sorts of diseases that can start with rash. And before you know, and that's where the diagnosis, the laboratory diagnosis comes in to help you get the proper attention on what we need to do. So yes, we need to improve on our surveillance. What I would think that with all of we mentioned, there's so many factors can be responsible. The fact that, you know, the expansion into virgin lands, into the forests, and bigger contact between man and rodents and all those kind of things are a factor that we're responsible. But it's not like what we're getting in the Europe. Now we know, and if the Europeans take note of that, I can see this epidemic actually coming down, once people get that information. As people have said, without stigmatization. Remember when people used to HIV in those days, people with blood transfusion can get HIV. It's not really sexuality. So these are some of the things that we need to explain to people. And therefore, that when you see a case, when you see a case and you follow the infection prevention and control system, you isolate the person as quickly as possible, you detect as quickly as possible. Those are the things we need to put emphasis on in our region, rather than running after vaccines that are not available. Over. Hello, can you hear me? Uh-oh.
Yeah, sorry, my mic was off. I don't know whether
okay.
Dr. Abiola also has any contribution. Before I pull up a data that I want Prof. thoughts on.
Okay, I think in terms of, I just have one or two things, maybe in terms of your former question on what should be the messaging, from journalists around some of these outbreaks. I think one of the things that also was clear is the increasing finding, like for instance, monkeypox, increasing appearance of monkeypox among people living with HIV. So we're also now seeing a lot of HIV monkeypox infection, which is also another thing to look at, and people should be wary for. Probably we'll get to some point. People with HIV also need to be screened for some other disease and all that. And also not to relax some of our public health health systems, that actually border health, and all those other things that we have started during COVID. This is not the time to also relax. Pandemic is not predictable and things can happen. You need to also have pandemic response established and on the ground at any point in time. It should be part of our habits as global citizens, rather than something that is one-off. I know some of those things that we did in COVID have been relaxed now, especially in most African countries and all that. So I just feel that we should do like more of our culture to really that pandemic awareness. So public health awareness is also something that is very important that journalists can emphasize around some of these diseases, educating the public on available evidence, things that we know already. I know there are a lot of things that's also not known yet, but these are some of the things I think we need to emphasize, and also to be able to use some of this advanced diagnostic capacity that has been established during COVID period. I know that a country like Nigeria, how many PCR labs do we have before COVID? But now a lot of some of these facilities are available. So countries should invest more, learning from COVID, to be able to have this capacity to diagnose some of these emerging diseases. It's not a time to relax, it's actually a time to do much. So I think journalists also need to write about some of these things. Of course, beyond animal reservoir, which is also not even validated, people should also know that human-to-human transmission is possible as part of the public health messaging that global journalists around the world will be able to. And also, I think things around microbial evolution, because nobody can actually explain why we're having more and more of these things coming up. So we really need to it's really of concern, and we need to really examine those issues, and also the relationship with some of these pandemics, climate changes and all that. People talk about deforestation, and so I think these are issues that we need to really tie together and be able to make sense of it. And research will actually help. But public health awareness is actually very, very important. A lot of misinformation happened with COVID. This is the time to start talking about providing the right education to the people about monkeypox and other emerging diseases. Thank you.
Yeah, thank you. Thank you very much. So data is always at the heart of very good public health and disease outbreak reporting. And when we started hearing all these issues around monkeypox, one of the things that I did was to compare the number of cases reported previous years with what is happening currently. And for journalists, one of the places that you have to do, especially if you're interested in reporting monkeypox in Africa from outside of the continent, is try as much as possible to lay your hands on reports. And we have some, thanks or no thanks to the COVID, some health institutions in Africa they've actually been up and doing in making public health data to be publicly accessible. And one of them is in Nigeria, is the Nigeria Center for Disease Control. So the website is ncdc. I want to show you ncdc.gov.ng. So if you're interested in actually getting analytics and updates and data sets on disease outbreaks in Nigeria, this is what you do. If you go up here, you're going to see publications. So click publications and look at situation reports. It is going to take you to this page that contains updates on situation reports on the different outbreaks. And so we have Lassa fever, we have meningitis, we have cholera, and we have monkeypox. So if you click here for monkeypox, you can see that this disease has been, Nigeria has been tracking this for long, but this is the latest report, and this is, I want to download it and show the Prof something, which actually, something is actually, there is a story here for any journalist that is interested in actually, you are trying to know what is happening differently in Africa this year. And please open up. So when you open it, as you can see, this report was published on July 31st, 2022. And this is where I'm interested in. If you look at the total number of cases confirmed, in 2017, we have 88 cases. In 2018, in Nigeria, we have 49 cases confirmed. In 2019, we had 47 cases. 2020, just 8 cases. Last year, 34 cases. But if you now go up here and now look at the total cases, total confirmed cases from January 1 to July 31st this year, we are not even at December yet. We've had 157 cases confirmed. Now, Prof, can we entirely say that this is just nothing unusual is happening? And I think data from elsewhere too might actually point to this. Can we fully say that nothing unusual is happening, and this is just due to advanced surveillance? And so what are your thoughts on this sharp, that seems to be almost 3, which is now already more than 5, nearly 5 times the number of cases reported last year, even though we are still in July in Nigeria?
Yeah, first of all, each of these data that you see, there's a pattern. During the COVID period, surveillance was in abeyance for other diseases. And so when you look at the pictures, can you hear me?
Yes.
Yeah, okay. So when you look at the data, 2019, 2020, 2021, there was a little bit of some, focus on COVID. And many of the other diseases, you find that with Lassa, you find that with yellow fever, you find that even with this one. So you're going to find a dip, in the 2020, 2021 because of COVID effect. But that also means one thing, that the disease is there, so the sudden upsurge, or which we are seeing now, could also be 2 reflections. One, in the previous years, we were not doing a proper surveillance because COVID took all our attention. Secondly, with the disease now in Europe and international bodies all interested, we too also became much interested and began to look for more of these cases. In addition to the message, what you are showing, there are also other centers which actually give you more information. That's for Nigeria. You want for DR Congo. There's the WHO Afro region, which has the outbreak, I think is weekly outbreak report that comes in, emergencies and things of that nature, which goes through all of the different countries. There's our world in data, which also give you information about all over. So you can pick up information from so many other sources, and catch up what is going on. So 2 things are happening. There was a little bit of aberration because of the COVID effect on surveillance in 2020 and 2021. I think we probably would have been getting about a little more figure they were getting in those years. So this sudden upsurge gives an impression that, oh, there's a big epidemic going on. I think it's been around. We're not detecting it. That's number one. But also to say that we're improving our diagnosis, the laboratories are there. I want to, what's the English word? Abiola was talking about we're having laboratories now, 140 and all that kind of thing. I think one message we need to learn from that, if you go back to that same NCDC center, you find that 70, almost 50% of those labs which we built up during COVID are no longer functioning. There's a page, I think page 5, where they list all of the labs that are no longer reporting. I think that's one message, sustainability. So we build up all this, not really because we needed them at that time. I mean, let's be frank with each other. The polio eradication in the African region was done with just 15 laboratories. If you plan your laboratories well to ensure access to everybody, instead of getting 140 and you have like 70 that you can consistently sustain, you are better off than all these building things. But I do know that the building of labs in Nigeria for COVID was not because they were interested in building in COVID, not because they were interested in contracts and building things. So they build, they won't staff, they build, they won't equip. And this is what is happening to us. So in dealing with this, learning lessons from all this one, look at what has happened. If 50% of your labs a year after COVID, COVID is still around, are no longer functioning, then something's wrong somewhere there. We need to learn a lesson from that also, to build what we can sustain, provide with the right equipment, the right staff. Over.
Dr. Abiola, I think we're in the last 3 minutes of this conversation. So what are your suggestions for journalists generally in reporting HIV, looking at, are there issues that you still think they are not looking at, that are not getting much attention? Is there anything that you think the global HIV coverage is not really getting intensive, is not getting coverage from your angle? And in general, what are your general advices for journalists that will be watching this later?
Yeah, so I think for me, I just want to speak in the context of African country, which I belong to. So one of the things I also noticed that most of the time we look at the medical angle to diseases, but for us to achieve disease control, epidemic control, whatever we call it, there's also that interplay between disease, culture, and all that. So one of the things I noticed in this country is that stigma around disease is still something very, very, unlike the West, that mostly they've overcome that stigma. You see, a gay man will come out and say, I'm a gay, the man will tell his partner, positive, if you want to stay, you stay. So we're still struggling with, and I think economy, income level and all those stuff also have, a lot of interaction around disease. So I think we need to begin to educate people more, around some of these things, cultural issues around disease control that is limiting our progress and all that. Sometimes you give a woman in antenatal care who is HIV positive, you educate the woman to bring the husband to disclose status to the husband. It's not still ready to do that. And I can't blame the woman. Empowerment, it's also very critical in some of these disease control. Some of the things that would have been very easy for us, but because people are not also economically empowered to take care of their lives, to feed themselves, and all. So these are some of the issues around disease control that, and they go unreported most times. A woman that doesn't have a job, is married to a man, is now found to be HIV positive, it's not going to be willing to disclose his status because divorce is going to knock on that door. How will he survive? How will the children survive and all that? So these are some of the barriers that go unreported in most cases that actually militates some of this. I talk about HIV self-test kits sometimes. One of the strategies we use across countries is also to use males. Since male partner will not want to come to the hospital, but most likely a woman will come to the hospital, even if has not come in her life, during her antenatal is likely going to come. I'm trying to educate women to provide these kits to their husband to be able to test together in the home and all that. But you also find that there are always some of these challenges, women willing to do that. just because they're afraid of what will come out of it and all that. So I think economic empowerment, the role of economic empowerment of women, gender dimension, gender equality, and these are some of the things that I think we need to also report more and support. There must be support mechanism to really support women, empower women more, to be able to take decisions about their health, about whatever happens to them beyond what anybody will say. I think that's one thing that came to my mind. I think we need to also pay more attention around, especially in African country, where gender and all those things are very, very critical.
So, Prof, what are your last remarks for journalists, for our journalists
Please,
today?
thank you very much. I think journalists should interrogate the data we are getting from our different centers. NCDC, you showed us the whatever it is that the NCDC shows. There must be a way where, for example, now suddenly we had, there's this upsurge in monkeypox, but these are reports that has taken over 3 weeks ago. We need more urgent data. We need people in the journalists to interrogate those data. I mean, when you tell me that there are so many cases and you don't tell me when the cases occur, and you're giving me a 1 month backlog of results, that's where journalists should come in and say, look, when did this occur? Is it now, last week? Is it this week? Is it 4 weeks ago? We need to go a little more into details or the data we're getting from our centers, and then together work with them to get a proper interpretation or for people to understand this and they listen. How many people will go to NCDC website? None, very few. Therefore, it has to be a way that together with NCDC and the journalists come out with an information that can appear in the newspaper so that people can understand it in a better way. Over. Oh.
So thank you very much, Prof. Thank you very much, Dr. Abela, and thank you very much for our journalists, the ones on Zoom, the ones watching us on IJNet Facebook page, the ones watching us on the ICFJ Pamela Howard Forum's page too. We appreciate you for joining us today. Like they have rightly said, when you see data, I think an important take-home message and lesson from this session is that when you see data sets regarding either HIV, monkeypox, or COVID from Africa or from any other parts of the world, the first thing that you have to ask yourself is to actually interrogate that data set so that you are very sure that you are not just seeing results of tests that were done over a large number of periods, to actually make your interpretation and report that there is a very urgent outbreak that is happening elsewhere. And it's always important for you to get the back-end stories regarding the different outbreaks and the particular situations of countries to another, so that you are not misinforming your audience. So thank you very much for joining us today. We appreciate you. For more information on the ICFJ Pamela Howard Forum on Global Crisis Reporting, I encourage you to check out ICFJ's website on www.icfj.org, and I also encourage you to be part of our forum, active forum on Facebook. Just if you go to Facebook, search for ICFJ Pamela Howard Forum on Global Crisis Reporting, be part of that forum, and we are going to provide you access with resources, knowledge, and several other things to improve your crisis reporting in different parts of the world that you may be. And a third announcement that I have is that you can also access resources on IJNet website, so that on ijnet.org. And one of the things that I think is really important for me to also bring to the attention of our journalists is our ongoing story contest. So if you're writing a story, if you've published a story in which you utilize any information that we are sharing today, ICFJ has a grant for you. So please submit your stories that you've written on any of these subjects to us, and it's going to be entered for consideration for this grant. I just put the link up there. So if you're a journalist and you are working on any story on monkeypox qualifies for submission. Its 2022 conference qualifies for submission. The COVID pandemic also qualifies for submission. So these are very broad topics that I believe you should be able to find a story to submit. And so thank you very much, Dr. Abiola. Thank you very much, Professor Tomori. And
My pleasure.
thank you very much, everybody. I enjoying accessing this on different platforms. And I say enjoy the rest of your day. Bye for now.
And thank you, Stella. You didn't say anything after that.
Oh, Stella,
Bye-bye.
Stella works the magic. She was the magic behind.
Yeah.
Yes. Damn,
Thank you. Thank
I'm
you.
going to be
Bye-bye.
in trouble today, Stella.
Bye-bye now.
Thank you.
Stella, thank you very much.
Bye.
Appreciate you.
Bye-bye.
Bye, Biola. Glad to meet you. Bye-bye now.
Yeah.